This is Sue Ann. I'm with the State Unit on Aging. Welcome to the ongoing 2015 ADRC webinar series by the State Unit on Aging. We're recording this webinar as we do every month, and we will post it on the State Unit on Aging website along with the materials, which is the PowerPoint this week. And it should be up by the end of this week or possibly early next week. If you did not get materials, they were sent out yesterday. If you did not get them, send an email to Lori, Lori.c, as in cat, .watt, W-A-T-T, at state.or.us. And in the subject line, just say, need materials for the webinar, and she will send them off to you. We do keep everybody muted because it gives us less feedback and static. Make sure you text chat questions and comments. And if you have a group site, please text in other folks' names so we know who else is there with you. At the end of the webinar, sometime in that next half hour, keep an eye out for an email with an evaluation SurveyMonkey link survey to let us know how we did. Today's webinar is Service Eligibility for Aging and People with Disabilities. And today I have with me Susie Quinlan from the APD Field Services Training Team. And she's here with me, and she's going to present some material. Don't hesitate to text chat. I'll be keeping an eye on the questions. So if you have questions, text chat them in, and we'll make sure that she gets them and sees what they are, and we'll try to get them answered. Let us know if there's any questions or any issues going on, and we're ready to go.
You want me to do this? So, hello. My name is Susie Quinlan, and as Sue Ann told you, I'm with the Aging and People with Disabilities. I work in the APD Medicaid Long-Term Care Systems programs, and the training I'm going to be going over with you today is about service eligibility for aging and people with disabilities. Remember, service eligibility is things like nursing facility, home and community-based care facility type services. Is that how you do that? There we go. Okay, so who does APD serve? So basically, this is not the same slide as mine. That's okay. The APD serves individuals that are either aged, so that would be, believe it or not, I have a hard time with this the older I get. These are individuals that are 65 years of age or older. They could be individuals that are 18 to 65, but they must have a physical disability to qualify, or some sort of physical condition that qualifies them. And once these individuals qualify for with one of those two criteria there, then they could potentially, once they're assessed, be eligible for what we call the state K-plan services. They could be eligible for waivered case management services, and they could be eligible potentially for state plan personal care services. I'll get into a little bit more detail about those individually in just a moment. K-plan is the primary type of service or the funding source that we offer our individuals that we serve, and those services are, they are the services that are provided for in-home services and for the community-based care services, facility services, and nursing facility services. So the waivered case management services is basically just another service case managers offer through a different funding source. They offer our consumers just to kind of keep track of what's going on and monitoring their case. And then the State Plan Personal Care Program, that is a program, it's a very small program. It's if a person is eligible, they could be eligible for up to 20 hours of service. Okay, so who administers all these services that I just talked about very briefly? We have 32 state Aging and People with Disabilities Office. The acronym for that is APD. And we have 16 AAA offices, so I think most of you know it, that is the Area Agency on Aging offices across the state that administer these programs. I have been corrected. I believe Joanne said there's 17, so this is probably older information. There may have been another added, or we are behind. Thank you. Going here. So nursing facility and state plan state plan K option. So remember, that is our primary service fund that we serve service individuals through. Okay, so individuals are eligible to receive services if they meet the service eligibility requirements tied to nursing facility level of care. So what this means is that these individuals, if they meet, first of all, they have to meet the financial eligibility criteria for Medicaid. And they also have to, when we talk about level of care, that is actually what we ultimately refer to as service priority level. So, and the acronym for that is SDL. Most of you have heard that. And we serve levels 1 through 13. Number 1 being the most in need, and number 13 being the highest need. So once eligible for these services, once eligible for SPL 1 through 13, then an individual would qualify for receiving hours for in-home services from a home care worker or an in-home agency. They could choose to go to a community-based care facility such as a foster home, a residential care facility, assisted living. And even though nursing facility is probably the least desirable for most of us want to be in the least restrictive environment, some people do still choose to go to nursing facilities, and some people it is the most appropriate. But that is an option that they have available to them. Go ahead. Oh, okay. So when you're assessing for services, we look at it as in order to even receive services or even to be assessed really for services, a person first, we have to determine if the person's even going to meet all the other eligibility criteria. So one way to look at it is there's different doors they have to be able to make it through, eligibility doors, before they would potentially even be assessed for services. So let's see. So in the next few slides, what I'm going to be talking about are those different doors. I talk about 3 different doors. So we'll, before you can even get into the Medicaid services. So they basically have to be eligible for Medicaid medical benefits to receive any of our services. So they either have to be receiving or will be receiving if they get services. Okay. Okay, so the first door is they have to, the individual must be, like I was saying on the previous slide, they have to be eligible for or will be eligible for either OSIP-M, which I'll tell you what that means in a minute if you don't know, or MAGI Medicaid Medical. Both of these are both of these are Medicaid medical programs. So what OSIP-M stands for, it is Medicaid medical, like I said, but it stands for Organ Supplemental Income Program, and the M is for medical. It's just a Medicaid medical benefit. And so to receive OSIP-M, the person must be at least 65 years of age. They could be, or it could be a person that is blind, or it could be a person that is disabled. OSIP-M is not just for physically disabled. It could be developmentally disabled or mentally disabled. And the disability, though, if they're under 65, is based on Social Security Administration disability criteria. Now, the second one, the first one I talked about in this door was OSIP-M. The second one is MAGI. MAGI is another Medicaid medical benefit, and we are, as an agency, we just love acronyms. MAGI is one of the many acronyms, and what it stands for is Medicaid Modified Adjusted Gross Income. This is, MAGI came about as part of the Affordable Care Act, and it typically is only for individuals under 65. Typically, they don't have Medicare. They're not on Social Security, or they might be, but before they get Medicare. And one of the benefits of MAGI for these, when you compare it to OSIP-M, MAGI does not have to be eligible for MAGI medical, you do not have to meet the Social Security Administration disability criteria if you're under 65. If you're under 65 for OSIP-M, you have to meet the Social Security disability criteria. So it's a much higher standard. So the MAGI door is a pretty much, if a person can get through that door, that is the easiest way to qualify at this level. So, okay. So a little bit about OSIP-M eligibility. So for OSIP-M, what we look at is the person has to, like I said, be OSIP-M medical before they can receive services. OSIP-M Medicaid medical eligibility does have some income resource limits. For a person that's applying for services, which is pretty, it's got a pretty high income standard, which is 300% of the SSI standard. And 300% of the SSI standard is like $2,199 gross a month. So once they meet, if their income is at that level and they meet all other criteria, such as the resource limits in the next bullet of a limit of $2,000 for an individual or $3,000 for a couple, then as long as they meet all the other, there's always a lot of other eligibility criteria that they might need to meet. They could potentially be at least eligible to be assessed for services.
There's a question that came in about whether OPI is covered under APD, and it's not an APD service, right? OPI is its own whole program, but it's not through APD.
Yeah, it's not a Medicaid program.
Right.
Right. So, yep, yep.
Thank you.
Know that one. So the other thing I just want to mention here, notice on the resource limit of $2,000 for an individual. One of the things that is very helpful for married individuals, a lot of times because of the community spouse poverty, we don't want a community spouse to be impoverished. I'm not even saying that right, I don't think. But anyway, some of the money can be diverted also to the community spouse that is not receiving Medicaid services. So there are a lot of different ways an individual could potentially qualify for services. So, okay, I think that's probably good enough for that slide.
And I've asked Susie to just go through the basics because we just wanted to give you guys an idea of eligibility. We don't expect you all to be the eligibility specialist because that's what APD does, and they have people who do that. But we wanted to give you a really good basic idea. So that's why she's presenting all this material today.
Yeah, and really, to get the whole gist of all this, this is like several weeks of training. So we're kind of condensing the highlights into an hour and a half or so. So,
and I'm seeing some questions about OPI. We're not talking about OPI today. We're talking about Medicaid and eligibility for those services. So if you guys have questions about OPI, you can shoot me an email. Question has to do with people being on Oregon Health Plan and food stamps and being eligible. So we will have to look that up because Susie works with APD, not OPI.
Exactly. Thank you, Sue Ann. But I would be happy to answer some of these eligibility questions, and I believe a lot of you do deal with Medicaid, at least indirectly, for referring and preliminary screenings. And correct me if I'm wrong, Sue Ann.
That's good.
Okay. Okay. All righty. So OSIP-M eligibility. So I am going to give you a little bit about OSIP-M because that's how you get through that's one of the ways. It's either OSIP-M or MAGI in order to be eligible for Medicaid services. So for individuals for OSIP-M that are under age 65, these individuals have to be determined disabled by Social Security. We have, there's two ways that this can happen. One is Social Security made that determination, or some people become disabled all of a sudden. Their Social Security disability hasn't gone through. So we also have a team of people called the Presumptive Medicaid Disability Determination Team. And what they do is they have disability analysts that they review medical documentation, they review the medical records, psych evals, and all sorts of different things to make a disability determination using the exact same criteria that Social Security uses for making a disability determination. So that's one of the hoops that a person has to jump through. However, now that MAGI, since the Affordable Care Act has come about, individuals that are under 65, a lot of them are not going through the OSIP-M eligibility pathway. They are going through the MAGI pathway clearly because it's so much easier, and a disability decision does not need to be made to qualify for MAGI.
Okay, Susie, there's a question about when you say eligible for Medicaid services, what services are you talking about? Home services, doctor visits, foster care?
Ah, okay.
Can you just give us
Yes,
an idea?
I
Good
can
question.
do that. Yes, thank you. When I'm talking about services, I'm talking about what we call, it's a state plan K option services, and what they cover are in-home services covered by Medicaid, that's paid by Medicaid, and they cover the service payments for individuals receiving community-based care facility services, which is things like adult foster home, could be a residential care facility, it could be an assisted living facility. Those are the primary community-based care facilities that we have. There are others. And we also cover the nursing facility services.
So it's in-home, whether it's individual home care workers or agencies, and then facility services, adult foster homes, RCF, ALF, and nursing facilities.
Yep.
Thank you.
Yep, you're welcome. Okay, that was a good question. I'm not sure how we are. I know we're different than mine. Okay, this is my lovely little chart here. And basically what this is about, sometimes some of us, myself, I'm very visual. This is just a chart for seeing what the flow is, or a pathway, as you might call it, for individuals, what they might need to, we might need to look at. As a case manager, this is what they look at before they determine would assess an individual for the services that me and Sue Ann were just talking about. So this is just hopefully a helpful chart. If a person's, what it's showing you here is if a person's already on SSI or SSDI, then they will be eligible, they could potentially be eligible to be assessed and receive those services. If they're not, they can, and they're not on MAGI, they would have to go through the presumptive path. Anyway, this is a helpful chart. I don't know if I need to go through each. Do you think I need to go through?
It wouldn't hurt to just.
Okay. So, first of all, if a person, is there a way to highlight things on here? Okay. If a person is under 65 years of age, at the very top it says there's a box for MAGI eligible, and it says if you follow the yes path, they go directly into being assessed for SPL services. If they're not SPL 1 through 13, go to the right of that box, and then you're going to assess them. It says SPPC. SPPC stands for State Planned Personal Care Program, and then they could potentially be eligible for that once we do another assessment. And if they're eligible for that, they would potentially be eligible for a minimal program that only serves up to 20 hours a month. Now, if we take this path again, so MAGI eligible, if you go down if it says no for MAGI eligible, and you say no, they're not on SSDI, then you would need to also assess them for OSIP-M. If they're under 65, the presumptive medical disability determination people will have to make a decision on whether they meet the disability criteria. If they do, then we assess them. So it's kind of a lot of looping around here to see what they have to do prior to being assessed and determining if they're eligible, and what service program that they might be eligible to receive. Okay. This next slide is actually the next. I believe there's 3 slides here. It's basically a chart that one of my coworkers put together. It's a really helpful chart if you need this type of information. And it's a comparison chart for individuals receiving or applying for services, comparing the benefits or maybe not benefits for a person that's either OSIP-M or MAGI. So,
and again, Susie's this is the first door into the services. She's going to talk about 2 other doorways in, but these 2, OSIP-M and MAGI, is the first door.
Yes. So some of the criteria on here, this is more for you to look at later, but I just want you to be aware, we've already talked about it, like the income criteria, OSIP-M has a 300%. MAGI, so our case managers for APD, they don't even determine eligibility for MAGI. So a person would come in already having applied for it, or we could potentially refer them. So we don't deal with the income standard for MAGI. So one of the benefits, the second one for resources, for a MAGI eligible individual, they don't have, when you're applying for Medicaid medical through MAGI, they have no resource limit, so a person could potentially have a lot of resources and still qualify for MAGI Medicaid benefits. And now OSIP-M has a $2,000 resource limit with some other provisions, like the community spouse provision I talked about. Once a person is eligible for MAGI, though, even though they don't have a resource limit, if they want to receive services, we do look at the resources for those individuals. So there are some very interesting differences. I'm not going to cover each and every one because I don't think it's necessary. This is available to you if you need it.
We have a question.
Oh, we have a question. I can't find it. Okay. You want me to keep going while you're doing that? Or could you go to the next? There, thank you. Okay, what I consider very interesting, and I think our APD case managers do too, a person has to pay for their services, even if they're on Medicaid. So an OSIP-M eligible person, if depending on what their income is, may have to pay a liability or a pay-in for receiving some of their services. Now, a MAGI eligible person that receives services because of the program rules, they don't have a liability or pay-in. So there, you can clearly see a benefit for the consumer for going through the MAGI door.
And you mentioned a couple minutes ago that APD, your folks for Medicaid, don't screen and find eligibility for MAGI, so who does the MAGI program?
Yes, and the MAGI program is done through a branch in Salem. It's called Branch 5503. I know I talked about that somewhere, but I might have skipped over.
So we're going to get to
Oh, no, I already did.
Okay.
I just didn't mention it. Or maybe I did. So anyway, it is not done by the APD offices. It is done through, initially it was done through Cover Oregon, and now we have what we call, we have acronyms and numbers for everything, branch number 5503, and it's done in Salem. We don't put any of the coding in for MAGI. We don't do any of that. Any of that type of stuff. The only thing we do for MAGI individuals is we set up services and monitor their service plans. Okay?
Thank you.
You're welcome. Okay, so let's see what else we have here. So another big difference between OSIP-M and MAGI is OSIP-M, we have some 461 rules that allow for some special needs to be paid for individuals on OSIP-M. So a special need could be something like they don't have any income yet and they need their room and board paid and their personal incidental funds paid for an assisted living facility. We could potentially pay that for them. Now, MAGI does not have, they cannot get OSIP-M, they cannot get special needs based on that same rule. However, we do have other ways of funding them, like their room and board, for individuals that have no income that are MAGI eligible, which some of them do not have income.
So Susie, if people in the field with the ADRCs were looking at these and looked like to them that their client was eligible for MAGI, who would they refer them to? If they don't refer them to APD office, who would they refer them to?
I don't actually have that information on me, but they could actually send them to the APD office, and then the APD office has applications for them, and then they will refer them on. That's probably the best route to take.
So still send them to APD, but mention to them that it might be MAGI.
And there is, I don't have this with me, but there is a website you can also apply for MAGI online. So there's a website for doing that. And both of these programs, just so you know, just want to make sure it's clear, OSIP-M and MAGI, both of them, their Medicaid medical benefits are exactly the same. There are some little glitchy differences that, like I said, one does have to pay a liability or pay in for their services, the other doesn't. So there are things like that. But as far as their Medicaid medical benefits, everything is the same. Let me see what else. Is there anything? I don't know if you want me to go through everything on here. I don't think it's necessary. I want to make sure you get through this PowerPoint with me. This slide here is just a comparison. One of the things I find interesting is that that for the Independent Choices Program, which is a service program that we cash out the consumer, and they then buy their services from individuals. Like it would be a person that gets in-home services that does not go through the home care worker program. We cash them out. So now notice on this comparison chart, they're only person that can get that is a person eligible for OSIP-M, not a person eligible for MAGI. The State Plan Personal Care Program, remember I said earlier, just briefly, it's a very small program, but it is out there. It's an in-home service program. Primarily, we offer 20 hours of personal care services and housekeeping type services per month, and either program, MAGI or OSIP-M, qualifies. And I do not think we need to go over all the rest of this slide, unless you want me to. They're pretty much the same thing.
I want to make note at the bottom there, though, that if they're on OPI, they're not eligible for either OSIP-M or MAGI. So if they have OSIP-M or MAGI, they can't do OPI.
Got it. Because that is not a Medicaid program. So, okay. So, guess what? We finally made it to door 2. Yay. Okay, door number 2 is, so it's going to be individuals that actually made it through door number 1, and now we need to look at door number 2, but door number 2 is only for a select group. They are going to be the individuals that are under 65 years of age. So in this door, what we're looking at is basically, do we serve them under APD's program, or does somebody else? And so we have to look at what agency is going to be better suited to offer services for the individual. These 3 types of services are for the developmentally disabled, and that's for DD, we call those DD programs in short. The mental health programs, AMHD is addictions and mental health disorders, so they would serve the mental health group. And then the physical, and we also have the physical disabled individuals, and those are the ones that are served by APD. It isn't really that neat and clean, though. It sounds like it's cut and dry. It's not really that cut and dry. So with that being said, I will cover some of that. Oh, will that work? Mm-hmm. Oh, I thought she said it didn't work. Okay. Okay, so individuals under age 65, those individuals with a mental or emotional disorder or substance abuse related disorders are eligible for nursing facility and K-plan services only if, number 1 there, you'll notice it says they have a condition, non-psychiatric or a physical disability. And the second one says that they have, their need for services is based on a physical disability. And the third one is they can show documentation that supports that need. Sometimes, so a lot of people need services that are under 65, but their basically it just means their primary need for services might not be a physical disabling condition. It might be something like they have schizophrenia. And we are not, APD is not as well equipped to serve those individuals as addictions and mental health would be able to serve these individuals. So we want the best place for the individual to be served, for them to be served at those places. Okay. So if the person has a mental and emotional disorder and is under 65, we are going to conduct a service eligibility. We're going to assess that individual first and to determine what is actually qualifying that individual for services. So that is the very first thing that we are going to do, and then we need to make a decision whether it is the need for that service is driven by mental or an emotional disorder. If a person, if the assessment shows that they do have a mental and emotional disorder and they don't also have a physical disorder that needs to be met based on that disorder, then we would make a referral to what we call the MED committee. MED stands for Mental and Emotional Disorder, and it's a committee of people that get together, and one of them is a psychiatrist as part of this committee, and another is a policy analyst that deals with mental health disorders, and several other people. They use the documentation that's provided by the case manager. They use the assessment that they did, and they make a decision if APD should serve that person or mental health. Okay. Use my chattering paper. So this slide is simply for the purpose of just showing you the definition that we use for mental and emotional disorders. And it's pretty, not a whole lot to it other than it's things like, it shows that it's things like schizophrenia, it could be mood disorders, paranoia. A person could have an eating disorder, impulse control. I'm not going to cover everything here. But basically, it's just something described in the Diagnostic and Statistical Manual. This is the definition in our SPL rule for mental and emotional disorders. So that is kind of what we use. It is what we use.
So there's a question about where folks should go if their need is based on mental health.
They would, oh, go ahead.
Yeah, so they just want to know is there a state agency that would have local county groups that would work?
Well, sometimes people come into the APD office and then we have to figure out who serves that individual. But, you know, it depends. Sometimes they're not screened out, but they are screened and they find out, oh, okay, this isn't the place I really meant to be. And the local office would refer them to the local county, AMHD office. So
county mental health folks?
Yes.
So these are information and referral folks and options counselors who might, in their talking with people, find out that they have some of these kinds of disorders. So rather than send them to APD, they would send them directly to their county mental health folks?
Well, that's a very good question, Sue Ann, because it's actually not, there's so much gray in what we talk about when you're talking services. And so a person with schizophrenia could also be a person with paraplegia. So guess what? The paraplegia is going to trump the schizophrenia probably if they need help, or maybe quadriplegia in particular. They are definitely going to, I wouldn't want them to be screened to go to mental health if they have other qualifying factors such as quadriplegia or other physical disabling things. And remember, too, this is for individuals under 65 years old. So if the person has schizophrenia and they're 65 or older, APD is going to serve them.
Okay.
So,
great.
Yeah.
Thank you.
Sure. Okay, so I think...
good questions, you guys. I know this is complicated, but we're, again, just trying to get the basics.
Okay. Okay, and I talked about this a little bit. So what the whole purpose of this team of people for mental and emotional disorders, the whole purpose is for those under 65 with a primary diagnosis and need that's driven by a mental health need. They make a decision on who will be serving those individuals. Sometimes where it gets kind of convoluted is we have individuals that are under 65 years of age, that they have what we call a TBI, which is a traumatic brain injury, or they might have some sort of dementia. They might have other physical problems like multiple sclerosis that have some characteristics now because of their disease that that resemble some of the mental health problems, and even like Parkinson's. So I would be really, if in doubt, I would always refer those to APD, any of these to APD, because even if they're under 65, if their cognition problems are not totally mental health, such as dementia, a person with that was in a motor vehicle accident and now has a traumatic brain injury, we're going to serve those individuals. So I want to be cautious about not referring. I would be more comfortable with over-referring than under-referring.
So over-referring to APD. And one of the questions that just came in, people were kind of curious as to whether or not there's sort of a CAPS-like assessment for these folks with mental health disorders, and I'm assuming that's what this team does that you've talked about.
And that is a really good question, but really what it is, we do have, I'm assuming everybody knows what CAPS is. It's what APD is it's CAPS means Client Assessment and Planning System, and everybody is assessed using the same tool, regardless of whether you have a physical disability, mental and emotional disability, or if you have developmental disabling conditions. So the same assessment is used once we are trying to figure out who serves that person. And then MED will look at that assessment to make a decision who will serve that person. Okay. You're welcome. Okay. Yes. And I actually got ahead of myself a minute ago, which that's okay. I'm good at that. This is just a team of people, and as I said, it has psychiatrists as a manager my manager is part of that, and several policy analysts, some from AMH, which is mental health, and some from the APD side. I am not going to spend a lot of time on this slide. This is just what our case managers, what they need to go through with MED for an individual when they make referrals to the MED group.
So if the person comes from the ADRC folks and gets into APD, and then APD screens them and determines them and believes that they might be eligible or have a dual eligibility of some kind, then this is the process those screeners would use to send the person to this team, who would then say who would be the appropriate folks.
Yeah, it's actually usually when it gets to MED, though, it's actually not at the screening level. It's already gone one step further. Sometimes at the screening level, somebody may just tell them, they might be just coming in to find out where to get services. Then the screener can say that. But it's when they get beyond the screening and to the case manager. Okay, we have a question.
CAPS assessment. People don't feel CAPS assessment are reliable for determining level of cognitive impairment, so how can that be considered a valid measuring tool?
Well, the CAPS assessment, and we haven't really gotten there, it actually covers 8 different areas of cognition. Well, 5 areas of cognition, which I'll briefly cover in a second, and 3 areas of behaviors. And some of it, I agree, our cognition rules need some, I would like to use the word tweaking, because they are a little bit cited towards a person with the TBI or dementia. But a lot of people have been going to SPL training, and we are covering the mental health aspect of it, how to assess those individuals too. So it is used for both. But I will cover maybe briefly, I'll see how in just a moment. Okay. So now we have to go through, door number 2 was the individuals that were under 65, what they need to get through that door, what they need to do. And door number 3 is for individuals that are 65 years of age and over. most of these people are going to be OSIP-M people because remember, MAGI is for individuals under 65. So let me see where I'm at here. So once you are 65 years of age or older, basically, remember with the door number 2, with the under 65, I focused a lot on diagnosis. For this group, the over 65, diagnosis no longer matters. I mean, it may help them assess, the case manager assess the person, but it is definitely not a qualifier for our programs. These individuals, the preliminary qualifier really is just being aged at 65 or older. So regardless of age, though, so door 2 and door 3, they must meet our service priority levels of 1 through 13, and which most of you probably hear the word it called SPL. And that is done, like somebody just brought up a minute ago in one of the questions, it's done through our CAPS assessment tool, and it's based on our organ administrative rules for the called the SPL rules, service priority level rules. So in this group that are over 65, if they are SPL 1 through 13 and they're OSIP-M, they will be eligible to receive services as long as, which the last slide talks about, they don't have a natural support that is fully meeting all their needs, assessed needs for that individual already. So sometimes, not a lot anymore, but it could be like the mother has applied for services, she's an 80-year-old woman, and her daughter is, or son or family members are providing for all of her care. They would be considered a natural support. So, alrighty. So now that we have jumped through every door, all 3 doors, there's not really that many doors, but there is a lot of eligibility stuff they need to go through other than the service eligibility. Now we can assess to determine if the person meets service eligibility criteria. So service priority level 1 through 13. So once to do that, we assess the individuals for, they are what we call the 4 ADLs. And what those 4 ADLs are mobility, eating, elimination, and cognition / behavior. So cognition and behaviors they put together. So those 4 ADLs have enough information in them. Those are the only areas that determine SPL 1 through 13. So if they meet SPL 1 through 13, then we are going to go on with the assessment, and we're going to assess the remaining ADLs of dressing, grooming, bathing, personal hygiene. And so the 4 ADLs are used, like I said, for determining service eligibility, but they are also used for service planning purposes. And all the ADLs, so the left and right side here, are all used for determining, for service planning purposes. And when I say service planning purposes, what that means is to determine, to figure out how many hours that person would qualify in these areas if they were in an in-home service plan. And also these areas are all, they are used for determining levels that a community-based care facility provider will be eligible to receive for that consumer being in their facility. So that is, in a nutshell, what those will do. And then, thank you. So then the next thing we assess for is what we call IADLs. And IADLs stand for Instrumental Activities of Daily Living. And we use them, primarily they're used for service planning purposes, and almost the whole purpose, almost, I'm not going to say 100% because there is some other purposes, but is for in-home service planning. So So once we have assessed, remember the ADLs on the previous slide, so based on those ADLs and a few other factors like the person's endurance and their ability to perform these IADLs, such as doing their own housekeeping, then we use these for authorizing hours for like a home care worker or in-home agency to provide housekeeping, shopping, transportation, medication management, and meal preparation. So these are all based on, for the most part, based on what their needs were in their ADLs. So if a person is not able, but one of the ADLs is mobility, they can't walk, they probably would have a hard time doing housekeeping, so we might authorize hours of housekeeping, using that as an example. Yeah, that's good. All right, so when we assess individuals, what we look at for assessing is we from today's date, so we did the assessment today, we look back 30 days, or we look back for the past month from today, and we look at what was happening during that time frame for their ADLs and IADLs. So we look at what their ability is to perform those ADLs. We consider any sort of assistive devices that they are actually using, and if they have architectural modifications, such as widened doorways, that type of thing. Without a widened doorway, they may need more help than if they had one they can get through with their wheelchair, for example. So we look back 30 days, and then we anticipate what, based on what we have found out how they're doing in the past 30 days, is it reasonable, can we predict that this individual will need assistance in the next 30 days and ongoing? So that's the time frame that we look at. So that we're going to look back to see what their ability was to perform their ADLs and IADLs. And do they understand the health and safety? What that means is, do they understand the risks and consequences of some of the things that are happening in their lives? Sometimes it's decisions they're making, that type of thing. Part of this assessment process, we allow people to make preferences, which is good. We want people to be able to make preferences on, for example, some people may be safer using a wheelchair. However, they want to use a walker, or they don't want to use a walker or a wheelchair. They want to be able to walk independently, but with somebody else helping them. We allow them to have preferences, which every single one of us wants to be able to make decisions for ourselves. So they can prefer not to use a wheelchair. We're not going to require it. They can prefer not to use a walker, and we're not going to require it. We're going to assess them based on what they choose to use. I hope that made sense. Okay, good. Do we have questions?
Not yet.
Okay. Okay. So a little bit on the service priority levels. Like I said, Medicaid serves, the service eligibility serves service priority level, SPL, 1 through 13, 1 being the lowest number is the most needy. And what you can see here from number 1, if you're an SPL 1, you're going to meet our rule criteria for full assisted mobility and eating and elimination and cognition. Clearly, that is a person with very high needs. Now, if you jump down to SPL 13, it could be one time a month need in either bladder, bowel, or toileting, which we call elimination. So that need is clearly not as great of a need as a person that is an SPL 1. SPL 3, in comparison, so somewhere in the, not in the middle, but somewhere in there, is a full assist in either mobility or eating or cognition. So there's a lot of different levels, one just being the most needy. So once the interesting part, though, we call this SPL is level of care for receiving nursing facility services. So when we assess these individuals, if they meet SPL 1 through 13, they can then choose any type of service they want to receive that we offer. And that could even be as high as, like I said earlier, as nursing facilities. Most of us would not choose that. Not that that's horrible, but it's still, it's the most restrictive. Okay. So if a person is an SPL3 based on cognition, so as I mentioned earlier, there are eight areas of cognition. And in order to qualify for based on cognition, they would have to be full assist in at least 3 of those 8 areas. 2 of them isn't going to do it. 5 assist isn't going to do it. They have to have at least 3. Most of these for MED, the ones I was talking about that are under 65, most of them are going to be SPL3 based on cognition and behaviors, and they are the ones that we send to MED. So I talked a little bit about cognition. Just so you know, I can't spend a lot of time on this. Clearly, I mean, I will spend some, but it is a full day part of the 3-day training for cognition and behaviors, at least 1 day. So there's a lot of information given out on this. And, you know, that training is open to APD and OPI as well. Okay, so they're in the 8 areas of cognition. There's 5 areas of cognition: the adaptation, awareness, judgment, memory, and orientation. And then we have what we call behavioral symptoms of those 5 areas of behaviors, of cognition, that are demands on others, danger to self or others, and wandering. So those are assessed both for all areas of cognition, not just for an individual with dementia-type disorders, but also for mental health and developmentally delayed individuals. Okay. Real briefly on cognition and behaviors, the things that, well, basically what our rule says cognition and behaviors means. It's such a silly rule, kind of, because it's very short, but it actually does say it all. It just means how the functions of the brain, which basically means, what that really means, is how an individual is able to, whether they have the ability to process information and whether they have the ability to use that information as well. So when you think of cognition, it is actually something that is happening in their brain, so the functions of their brain and how they can process and use that information. It's not based on, and this is where it gets kind of convoluted sometimes and confusing, it's not based on personality traits or grumpy people or irritating people, but it's kind of what's happening in the brain. Something's not really working correctly. The other one it gets kind of confused with this area is people start looking at poor choices that people make. People make poor choices. It doesn't mean the functions of their brain, as simply put as that, are not working properly. They just are making poor choices. Everybody makes poor choices at some time in their life. And what we look at is, do these individuals with cognition problems, do they understand the risks and consequences of those choices? And just in a nutshell, a good way to look at that is a poor choice could be eating a candy bar when you have diabetes, but understanding the risks and consequences of doing that probably means that it isn't a cognition reason that they're making that choice. Okay, the second bullet talks about how we assess individuals for services. And we have a 30-day look back and look forward period. I talked about that a little bit ago for assessing a person. But in cognition, we can expand that and go back more than the 30 days. So what that means is what would happen if that individual, so let's say they're in a facility now, what would happen if that individual was left on their own, in their own home to take care of their own cognition needs or their own needs, or feeding themselves, that type of thing. Sometimes we can go back and look from prior to when they were in the facility and continue, because we don't want people to lose eligibility because they have these great, wonderful supports of a provider or family member. The care setting might be now offering such great support and guidance that they no longer, some of their symptoms of their cognition problems aren't appearing so dramatically as when they were on their own. So we can expand that time frame. We can expand it however long we need to. There's no time. We can go back 2 years if we need to. So that's one of the things that's kind of helpful for cognition. And it also, the third bullet here just says for cognition, it has to be that we're going to be assessing somebody as needing something. Something has to be being done for that person, or they need the assistance of another person. It could be supervision. The last bullet talks about lack of medication management. Some people are not, or lack of medication or lack of medication management. We don't assess that in cognition, so as we don't consider it a support. So if a person's for example, if a person is schizophrenia, or bipolar, we'll use that, and they have symptoms of bipolar that can be managed with medication, we assess them while they're on their medication, if that made sense. So what I'm saying is we don't look back beyond without that support of medication. We look at what is actually happening. If they're taking medication, we assess them with their medication, what their condition is. Okay. So another area that we assess for eligibility purposes is mobility. There's two pieces of mobility. There's ambulation and transfers. So in order to qualify for mobility, it requires for both of these areas, a person must require hands-on assistance, which means physically, somebody helping that person physically to ambulate, so walk about, regardless of how they walk, wheelchair, walker, on their own 2 feet, and also with transferring to and from a bed chair or wheelchair. So it does require hands-on assistance from another person. Hands-on could mean an individual pushing a wheelchair that they're in. We consider that hands-on. It also could be holding onto their arm while they walk. Ambulation, we assess both inside and outside the home. Transfers, we only consider inside the home or care setting. So those are different qualifiers for in mobility. Now eating, we have a silly rule. What it says, it's the activity of feeding and eating. So basically what it is simply getting food, their ability to get food into themselves. So it could be through into their mouth, using an eating utensil such as a fork or spoon, or it could be somebody with a feeding tube, and whether somebody needs to set that up for them. So it's not things like sometimes people get mixed up with eating with preparing meals for the individual. It's not preparing meals. It's actually getting the food into their body. It's not cutting up the food. It's the actual act of getting it there. So in eating, we look at things like, does it require hands-on assistance? We allow somebody, if all they need is cueing to help them, getting the food to their mouth. walking them through, pick up your fork, put the keys on it. Now you need to put the food in your mouth. That's considered cueing. That's in the eating section. And we also allow for monitoring in case a person has any choking or aspiration risks. We look at how frequently the need is. Some people need to, the criteria is to have a daily need of assistance, but a person with a medical condition might need it not daily. So it could be somebody like, for example, with multiple sclerosis, and they have ups and downs, and so the ups and downs, some days are good and they can feed themselves, and some days not so good, and they need somebody to help us. The next bullet, we look at their ability to feed themselves. So a person with quadriplegia, maybe somebody will have to attach the assistive device of a fork or a spoon to their wrist or hand, so how they function once that's put on. We require somebody to be at least within sight when they're eating. So if what they're qualifying for is they need monitoring for choking, they need to be pretty close to that person. And I already talked about choking and aspiration. And this is also, like I said, where we capture the need for feeding tubes and nutritional IDs. Okay. So the next category is elimination. And elimination, like I said, is taking care of bladder care, bowel care, and toileting. So there's 3 areas that we assess. Bladder care basically is the care needed that is associated with the bladder. I mean, so it's pretty obvious. It doesn't need a lot of explanation. It could be a lot of individuals qualify based on needing assistance changing their incontinence supplies, like their Depends, that type of thing. It could be they need a toileting schedule. Some people's bladder needs are pretty much harder, and they might be catheter care or ostomy care, that type of thing. We also allow for monitoring for a person that gets frequent urinary tract infections. The second one is bowel care, and this clearly is a needs associating with a person's bowels. And the most common one is changing incontinence supplies. But we have some very high needs individuals that we also have to provide. A person like that has quadriplegia may need digital stimulation of their bowels, so somebody needs to do that for them to have a bowel movement. It could be a toileting schedule, suppository insertions, ostomy care, enemas, and that sort of thing. So toileting is the third piece of elimination. And basically it's kind of a lot of, partly is mobility needs, but are mobility needs that are around the toileting area. So it's getting to and from the toilet and getting on and off the toilet. It could be the person needs somebody to cleanse them, so wiping after elimination. Somebody that needs their pants pulled up, their clothes adjusted, zippers zipped, that type of thing. It also could be somebody that has assistive devices and needs somebody to clean it or maintain it. An assistive device would be something like a commode or a raised toilet seat, a urinal, that type of thing, and somebody has to maintain it and clean it. The other area this covers is cleaning up the toileting area. If the person is creating an unsanitary condition that is a health risk to themselves or to other individuals. So that could be a qualifier for an individual as well for SPL. So we are coming towards the end. So basically here is just a quick slide. The role of our APD case managers is to determine financial and service eligibility, as we've talked about, and to assist the individual in determining appropriate services. So offering them options. One of our requirements that the case manager needs to do is once an individual is eligible, they need to offer them service options, and that means asking them what type of service they want. Do they want in-home services? Do they want to be in a community-based care facility or a nursing facility? Tell them what their options are and make sure they're aware of them and let them make an informed choice. Let's see where else. The other thing, well, clearly, is creating and improving service plans, and they partner for just discharge planning with hospitals and nursing facilities as well. But the other thing that's not on this slide that they do a lot of these days is they do a lot of monitoring and reevaluating the individual service plans to see if the service plan is meeting their needs. And they actually are now required to do that at least once a quarter, have some sort of a personal contact with not necessarily at their home or in person, but with the consumer. And I just whizzed right through those, didn't I?
So we'll kind of give a minute or so here and see if people have questions. Again, if you guys were in a group setting, we need you to text us in who the folks were that were with you there. I want to thank Susie a lot because, as she said, she normally does this information presentation in about a 3-day training, and it's in front of the computer with hands-on, looking at the caps and looking at Oregon Access and putting everything in, and so it's in a bigger context, and we asked her today to kind of pull that information out and give it to us in a nutshell. So I know it was kind of in the weeds here and there, but hopefully it was helpful as we went through the service. We went through eligibility. We went through the different doors to get in. You know, what are some of the different eligibility criteria, and then what are some of the services, and then what do they assess to figure out what services they need. So I think that was probably really helpful. I want to make sure that you guys know that we did record this. And so it will be on the website, and we will stay on for a few minutes in case people have other questions. I want to make sure that you guys know that we will do this again next month on May 13th in the afternoon, and that topic is falls prevention. I think it'll be a good one. We've had this gal talk with us once before about activities for Fall Prevention Month, and she's going to come back and talk with us again. So I'll get a better description from her and get the registration information out for everybody. That's May 13th in the afternoon, 1:30 to 3. So please mark your calendars. Susie, any last minute things that you can think of?
No.
Okay.
It's just a lot of information in a very short period of time.
Again, I want to thank you, Susie. I really appreciate it. We will, you guys need to watch for a survey, an email from Lori Watt, which will be a SurveyMonkey link to an evaluation. It's a very quick one. Let us know what worked for you, what didn't work for you, and what more you'd like to know about Medicaid and service eligibility. Because I know I'm hearing from people that there are other bits and pieces we want to know, and we can either have Susie back or one of her teammates if it's a different topic, but we want to make sure we get you guys the information you need. There were a couple folks who had OPI questions. Go ahead and email those to me, Suanne Jackson, SUANNE.Jackson@state.or.us, and we will get those OPI questions answered. Thanks to everybody for joining us today. I'm not seeing any more questions. Oh, let's see. We do have another question. Let's see here. People are thanking. Thank you very much, Susie. And we did get, there was one site from Washington County. You guys had a site that had several people, so thank you for sending us who all was there. And again, we'll stay on for a couple minutes in case you guys have questions for Susie, but thanks very much. And we will talk to you next month. Have a great one.
Oh,